Hey everybody, this is Erica Mello and welcome to Tough to Treat. And before I jump into a brief description of the episode, I wanted to mention an event that Susan and I will be hosting at CSM, our combined sections meeting in February 2020 in Denver. And it will be on the day before, I believe, Wednesday. So CSM starts Thursday to Saturday. We will be hosting a one-day clinical mastermind on that Wednesday before, bring us your tough patients. We can talk clinical. It's all about clinical reasoning. And we're formalizing the details. So if you are interested, either email me at erica@ericamello.com or Susan at embodied-pt.com. And or you can opt into our website, toughtotreat.com, and you'll get a couple PDFs from us initially, and then you'll be updated with regards to the mastermind. Hope to see you there. It'll be lots of fun. So on to the episode. This patient is a patient of mine who I am currently seeing. I've seen him on and off over the years for issues primarily related to his lumbar spine. He is post-op back surgery 3 years now, and lo and behold, he still has symptoms. Much decreased, however, they are still there. So Susan and I talk about a secondary complaint that he had, bilateral foot pain, mostly mostly on the right side, that was aggravated after 3 failed epidurals. So is it neural tension? Is it coming from something right in the lumbar spine, or is it a foot issue? So hope you enjoy it. Bye. Hey everybody, this is Erica Mello, along with my fabulous co-host, Susan Clinton. How are you today, Susan?
I'm good today, Erica.
Happy
fall.
Happy fall, and I know we talk a lot about the weather, but we actually have some sun today. It was so bad the past few days with the rain here in New York. We did need it for sure, but we've had issues with weather a lot this year, so for me, it affects my mood. It really does. Okay, are we ready to start?
I'm ready.
Okay.
What do you have?
I have a patient who, just flipping through his chart, it's kind of thick. I've seen him on and off for many years for various issues, mostly relating to his lumbar spine. He came back to see me in June of this year, and he's in his early 70s, and no children, is married, pretty sedentary. He does like to walk a lot. So in New York, he likes to walk to Central Park. So he lives by the East River, if you're familiar with the geography. So he has to walk about 20 to 25 minutes to get to Central Park, and then he kind of goes. So that's what he loves to do. And because he couldn't do that, that's why he came back in to see me. So his chief complaint was right leg pain, primarily in the anterior shin. So right butt skips the thigh and goes into the anterior part of the lower leg. And he also had bilateral foot pain on the balls of his feet, on both of them. And what aggravated him besides the walking was going from sit to stand after long bouts of sitting. So this was back in June. So I will fast forward a little bit. He has actually had back surgery in 2016 where they did a laminectomy. I saw him prior to that as well, probably in 2013, 14 for some various back issues. He always, got better, and then he disappeared for I would say a year. year and a half, and then he woke up one day and he could barely move. He was limping. So I didn't see him in that time frame, and he ended up going to his neurologist, and they suggested back surgery. He didn't even he just did it. He didn't have therapy, nothing. He just went and did it. So that was about 3 years ago. The symptoms before he had the surgery were very similar: right-sided butt pain, right shin pain, bilateral foot pain. The intensity of his symptoms after the surgery decreased dramatically, but he still was getting them. So I'm just looking if there's any other major past medical history on him. He's had three, prior to his surgery, he had 3 failed epidurals. He felt like his feet were getting quite weak. He wears orthotics for eons. And that was something that he's worn. He, excuse me, a year ago, he changed his orthotics prior to seeing me. So in 2018, he moved to a bigger shoe to accommodate his orthotics. He went up a full size, which doesn't really make sense. He also had a hernia operation 1 year ago. And he had something, I don't know what type of surgery because he didn't remember. Something he had prostate cancer. And he had surgery related to the sphincter there. I don't know, much about that, Susan. Maybe you would know, but he couldn't really even tell me what he had. So that was pre-back surgery. So that was 2015, because I wasn't treating him at that time. So he had the prostate surgery. He had the back surgery. So prostate surgery, he had back surgery 2016, and he had a hernia repair in 2018. Typical medications, your normal Lipitor, et cetera. No, he's on gabapentin, he's on Ambien, et cetera, et cetera. So do you have any questions before I move on?
No, not right at this moment.
Okay, so he had a lot of GI stuff, was on Prevacid, Prilosec, et cetera, et cetera. When I first saw him, I'm going to fast forward because I'm still seeing him and I'm kind of at a point where I need another opinion. So I treated him. So in the summer, he has a house out in the Hamptons. So I saw him intermittently over the summer. We got rid of his so when I first saw him, he had a significant right lateral shift, not unusual. A couple of the functional movements I did, I had him do a lumbar bend, forward bend. He had no change in his symptoms at all. The right butt pain was still there. The right leg pain was still there. I corrected his shift and then had him bend forward. Nothing, no symptoms. Back bending, nothing. Left side bending, nothing. Right side bending, positive. Not surprising. When he walked on his heels, ironically, he was not weak, but he felt it in the ball of his feet. And less so when he walked on his toes. I didn't do that for like a myotomal, although I did. I was really more interested in what was going on with the feet at that point, because the feet were secondary at the time. They are in June. So the only symptomatic lumbar movement in standing was right side bending. I had him get on, said heel walking was worse than toe walking. I had him go on his elbows on the table, prone on the elbows, no problem. Prone on elbows right, no problem. So his issue was sit to stand when I first saw him. I had him narrow his base of support when he went up from sit to stand versus just having a normal base of support, and his leg pain got better. So we went from a wide base of support, his normal, and then we went narrow, ironically, and he got up and he was much better in his leg. So that's what I did. That's what I looked at the first visit. You still okay, Susan?
Yeah.
Okay, so I gave him the first visit because he was going out east. I actually gave him, excuse me, I like the child's pose because I always give it out to a lot of back patients who have issues with extension or side bending. So I had him get into child's pose, move his hands to the left just to open up that right side. He'd been doing a hip flexor stretch post-back surgery. I reviewed that with him. He liked to do it.
I was like, fine. I didn't see anything wrong. So it was mostly in that half lunge position with the right leg back. I had him lift his right leg over his head. I had him, every time he did a sit, to stand up and narrow the base of support. So that's what I did the first visit. And I didn't see him for some time, and then he came back, and actually he was worse in the morning as well. I'm sorry. That makes sense. His MRI, he had an MRI, and a typical MRI, facet degeneration, you name it, it's like a typical 70-year-old back for someone who's got a lot of arthritis. He's hung up on the MRI report. It shows retrolisthesis, central stenosis, everything that you would expect he has. And he's extremely fixed on that, and he's looking at the soft tissue edema, the posterior disc bulge, etc. So I went and explained a lot that to him to hope, in the hopes that it would de-threaten him. So when he came back after the first visit, he said getting out of the sitting position with the narrow base of support was working. Walking was really the issue. Okay, so he said he felt better when he was walking, but he still got it. So the sit to stand, we nipped in the bud with the narrow base of support. Okay, he was feeling better in the morning. So I'm going to fast forward. Okay, because he ended up. I did some opening techniques the first couple of visits after I saw him in the middle of the summer.
Okay. I have a couple of questions before you fast forward.
Oh, go ahead.
So, how long has he been on the GABA and the Ambien?
Oh, probably for like 2 years.
Okay, since his back surgery?
Yep.
Okay. And
he's taking GABA 4 times a day.
Does he know why he's on it?
Well, he's like, oh, they gave it to me for the nerve pain.
Okay.
Yeah, that's what he told me.
And he doesn't sleep, so that's why he's on the Ambien?
Yeah, I don't know if he takes Ambien. Yeah. Everybody seems to take Ambien these days. It's ridiculous. I don't even think it helps. But he is, yes.
And then, okay. And he has GI issues, which is why he's on the Prilosec.
Yeah, and he's on, I'm just looking, Clonase, that's probably for the prostate. And fluoxetine, I've never heard of that one. Fluoxetine?
Flonase is for his sinuses.
Right, but no, this is Clonase, he wrote.
Clonase, okay.
Clonase. And losartan.
Okay.
I've heard of some of these.
Those are blood pressure.
Losartan, okay.
Yeah. So, okay, I just wanted to get a handle on how long he'd been on the GABA and if it really was helping or not. So it sounds to me like there is, basically right lateral shift feels better in prone, means he doesn't like compression.
Right.
Narrowing his base of support up kind of knocks the neural tension thing out, but neural tension can be weird. But it sounds to me like 100%, just listening to the story, that this guy is that we're dealing with somebody that is having a lot of catastrophization around his stuff.
Totally.
That this is a pretty involved pain catastrophization cycle.
Yeah.
It sounds like he's a confronter because he's trying to move. He's pushing through. Yep. He's pushing through the walking, so he's not really avoiding, but he can't, at this point, he can't walk, so now he wants to help, so he can. So it sounds like he pushed as long as he could until he couldn't anymore.
Right. He's so afraid of getting back into those acute symptoms because that never happened before to him. Mm-hmm. And I was like, well, things happen in life, and your back surgery took down the symptoms a notch, but it's not going to take it away. Mm-hmm. He's the kind of person that when a doctor tells him something, he believes it's like the book of Job. This is the Bible, right? Yep. So I had to sort of tell him, well, not always, it's just because someone, tells you that you have a ton of arthritis in your lumbar spine and you have this, this, and this, that doesn't mean it's the end of the world. And
and it doesn't also mean that that's the reason that you have pain.
Correct. It's hard sometimes to explain to these people, who I think are somewhat. I mean, you okay?
Yeah, sorry.
It's like I mean, he's fairly educated. I mean, I don't.
Mm-hmm.
But I just really think he has. He's just got a lot of psychosocial issues, I think.
It's got some fear motivated
Mm-hmm.
belief issues.
Mm-hmm. Mm-hmm.
So based on the
For
words
sure.
that people have used in the past with him, which is unfortunate.
Yep. Yep. So we will. So what I did was, I sort of tried to debunk a lot of that, and then he came back the middle of the summer, and he lives by the beach out east. So he told me that when he walks barefoot, now bear in mind he has orthotics. He sees a podiatrist. When he walks barefoot in his house, barefoot on the sand out east, he has no symptoms. None. He could walk the entire time on the beach with his no shoes on, and he feels fine. So we have sit to stand, nip that in the bud. I tried. So for example, so he told me that. So this is where I'm at now. So basically, all the decompression techniques that I did over the summer, the child's pose, I had him go from sit to stand to nip out the neural tension. I had him do some, some basic stretches. I didn't see him a lot, so it was mostly, managing on his own. I did do when he came back, I did check his lumbar, his accessory joint mobility. I did that actually at the evaluation. He's hypermobile. Not surprising. He didn't need to sit there and be massaged and mobilized or anything, so I wanted to give him a couple things to do. But what got me stumped, which is where I am today, is both feet. His butt pain is gone. His leg pain is gone. With minimal therapy, I mean, I would say 3 to 4 solid sessions over the summer when he was back and forth.
Mm-hmm.
But he did note that he's much better walking without shoes and on the sand. He also told me that when he takes his sock off his shoe and just wears the shoe, he's better. So I was like, okay, interesting. He wears Hokas, the rocker bottoms, and he feels not so great in those. I'm like, well, why are you wearing them? You don't feel so great. He feels better in slip-ons. So I'm thinking, do I have a foot issue? Do I have a neural tension issue still, but it's localized? Do I still have a spinal issue? And he went back recently. So I told him to take the orthotics out. At one point, I was like, take the orthotics out, see how you feel. Walk to Central Park, go 25 minutes. And he did, but he had, it didn't make a difference in terms of his pain in the balls of his feet. His right foot is much worse. So we can forget the left. It's really the right foot. That's a symptom he had pre-back surgery. That symptom didn't get better with the surgery.
Mm-hmm.
So I'm wondering I've assessed his foot. So I went in, I assessed his foot. He's got, a rigid foot, completely, no joint mobility in the rear foot, midfoot very stiff. When he stands and walks, he bears a lot of weight on the outside border of his foot, very rigid supinated foot type. But I'm thinking if he had some nerve root issues that would make, that affected that particular part of the foot, that makes sense. He did tell me that when he got the epidural, when they went in, he felt his foot got much worse after the epidural because they may have nicked the nerve. So he got the epidurals, his foot pain came on, he never got better after the surgery. So he didn't have the foot pain until he had the epidurals.
Mm-hmm.
So I'm not sure in the sense that, I don't want to go down the route of treating the foot because I think it is a central problem. However, I'm trying to make heads or tails of what walking on the beach well, everybody feels good barefoot on the beach, but I'm thinking maybe you're trying to stabilize your lump. I'm not sure, to be honest, because he does a lot of walking, and walking on the beach is kind of hard. You have to sort of use a lot of sort of low level stabilizer muscles. I'm thinking maybe that's trying to stabilize him, but I don't know. What are your thoughts so far?
So, my thoughts is that he needs to get out of that rocker shoe.
Yes, that's exactly what I told him. Yes.
Forget the orthotics. He needs to get out of the rocker shoe, and he needs to be in a shoe that his feet actually work.
Yeah.
Because that he feels better barefoot. It's because his feet are allowed to relax and to work.
Yeah.
And when you're in a rocker shoe, you don't work, your feet don't work. You just rock. Yeah. And this guy's a walker. He doesn't need to have a rocker shoe.
I know.
So that would be my first thing is like, okay, if you feel better this way, then that's what you do. You just go with it.
Yep.
Let's go with the slip-on shoes. There's great slip-on walking shoes. You can find different ones. And just let's start scaling it up and see how you do. How far can you walk without pain? And then back off, so that you're walking. So if you can walk 15 minutes without pain, that's great. And that may be part of the other issue was that at home, he's only walking for small bouts. And on the beach, he probably was, I don't know how long he was walking, but he was walking different because you have to walk different on the beach. It's a different substance, kind of thing. But with the other walking, he's going to have to kind of like begin to scale it up rather than, because you did the challenge, which is what you have to do. But I would take him back and start scaling the walking with different shoes on so that we can see, like, okay, if you feel good with slip-ons, let's put them on and let's go. And let's find out, when does the pain actually start to come on? Is it immediate or is it 15 minutes down the road or whatever? But if he doesn't have pain walking barefoot, or he doesn't have pain in the slip-ons, how far can he walk in those slip-ons before his pain starts? That's what I would want to know, because that's where he has to work.
Yeah.
What he's trying to do is figure out what he can wear so he can just keep doing whatever he did before, and that's not going to work at this point. He's so sensitized that he's going to have to back off and let that sensitivity begin to change. And which can be good for him. Are you doing any kind of work with him with his leg and like laying on his back with a long leg? Canvas strap around the foot, pulling the leg up, or anything like that for tension stuff and things like that?
Yes, I gave
that. Does that bother
to
him?
No.
Okay.
It doesn't.
So it's just compression that bothers him.
Yeah, I gave him the the peroneal nerve bias. I gave him neural tension, straight leg raise, adduction. I gave it all, wound him up, but good, and he still does those.
Yeah,
I thought at some point. Yeah, it was. I mean, I think narrowing his base of support got his initial symptoms much better, and that's the neural tension piece. And I'm like, yes, you had the epidural. Yeah, they could have nicked a nerve. I mean, but that was how many years ago now?
Yeah, that was
3 years ago.
Yeah. So now the nerve is sensitive. It's whatever's happened is healed, and now we're left with a sensitivity.
Correct.
For sure in there, and so we need to just keep all of that moving.
Right.
The interesting thing for me is the prostate cancer and the surgery he had for prostate cancer and foot pain seems to have all started about the same time.
Yes. Could
be coincidence, could be causal. But, when you're dealing with the prostate and you're dealing in that area, you're dealing with that, the S2 to S4, nerve roots that come out in and around. He could have developed a sensitivity. Maybe something got nicked, who knows, maybe the epidural, and maybe the sensitivity of the S2 through 4 nerve roots because of the prostate cancer. I don't know, but it sounds like a perfect storm.
Yeah.
And so that's the ball of your feet is S2. So
yes, that's correct.
So maybe the act of walking and moving his body over is enough to bring that on. And when he was walking on the sand, he was walking differently. I would ask him, show me what you look like when you walk on the sand. He can show you.
Yeah.
Just see, how does that feel right now? My question would be, what would happen if you had him stand barefoot on his feet and you just asked him to start doing some sways, like sway forward? And because I know when you went up on the heels, it seemed to make the pain worse in the bottom of the feet. So that kind of sounds a little nervy to me. Right. But I'm wondering the opposite. What if you had him just stand with his feet flat and he just swayed forward?
I could do that. Yeah, I didn't do that.
And then sway sideways, and so the whole body's staying still, but he's swaying on his feet.
Right.
See when that comes on. See if you can find the edge of that, and
Yep.
he can kind of start working that.
Yeah.
That edge, and then he can also stand there and say, "Where are you on your feet right now?"
Yep.
And do they hurt? And if so, I want you to move. I want you to sway your body around till it doesn't bother you.
Yep.
Let's find that position.
Yep.
And start kind of messing with that a little bit, because this is a little bit tricky for him.
Yep.
With all that's been going on.
Yeah. What's interesting is I did give him those neural glides, and he's been doing them. When I watch him walk, I mean, he's right-handed. So when he walks, I was trying to have him do some carries. So when he was walking, he literally dropped into this right side bend, right side bend, right side bend, right. And I'm like, okay, let's put a weight in your left hand so you can counterbalance, get over. Or I tried it in both hands to see if I could equalize, not that he's going to look perfectly symmetrical, but I wanted to see if I could sort of decrease that gravity pulling him down on that right side.
Right, because that's where his symptoms get kicked off. So.
Right. So
has he tried a telescoping hiking stick?
No.
That would help him stay upright. And they're cool. Everybody uses them.
Yes. Yeah, you mentioned that one time before on a podcast, right? Telescoping. Because he likes to go out east. I mean, it's beautiful.
I mean, if he wants to go find a cool stick, he can do that too. It's just that the telescoping ones are nice for people who just want to, telescope it down and not have to carry a big stick around. But he's not driving, so if he wants to find a cool, nice, go to some sort of store and find a cool, nice wooden stick, that looks good or has runes on it or whatever.
He's so funny because when he came in to see me, it was like the sit to stand, because he sits a lot, right? And doing a little bit of child's pose and a little bit of just basic awareness of your posture when you go from sit to stand, and the neural tension, he got better. And that was like 4 visits. But the secondary issue was the bilateral foot issue, and that's what had me. So,
and it's much more the long-standing issue.
Right, correct. So given all his history,
it came on a lot sooner. Yeah.
Correct.
So
go ahead.
So is that why he went to the podiatrist to get orthotics?
So he's had orthotics for a while, but listen to this. I said, I saw him this week and I looked at his shoes. I'm like, Hoka's? Why are you wearing Hoka's? And he looked at me. He's like, oh, well, the podiatrist said I have arthritis and I need those shoes. I went, what? I was like, this is what I'm saying. You're believing this stuff. And I'm like, this is the last thing that you need. You got to get out of the shoes. You got to get out of these shoes.
Well, the question for him is why do you think that is?
I know.
Why do you feel better barefoot
than
you do in these shoes? I mean, his inner wisdom is there. He's just not trusting it.
Right. I mean, we had this long discussion about that.
It's like, and he just needs to kind of okay, well, let's see what happens without them. Let's just see. They served their purpose in the beginning, perhaps, but now they may not be serving their purpose. Just like the way you were doing things before was fine until it wasn't fine. Right. And you had to find a new way. Now with your feet, you may have to find a new way.
Right. And I think he's actually going to get new shoes, because he said to me, I want to get something in the middle between the slip-ons and the Hoka's. I'm like, okay, but you feel good in the slip-ons. And he got those post-back surgery because he felt better. He just for bending over and things. So that's what he's doing now. But I felt that it still is a neural issue. I don't necessarily, like he was saying to me, he's like, do you think it's like a foot mechanics? I'm like, well, it certainly affected your foot. Your foot's very rigid, but the aggravated nerves will do that to your.
But you've had those feet your whole life, yeah.
Yeah, I mean,
it was a foot issue. I don't know.
Yeah, no, I would agree.
If it was a real mechanical issue, it wouldn't feel good no matter what you had. If it was arthritis, it wouldn't feel good. No, if we can blame arthritis, which is crazy, but we do. If it was that, it would hurt no matter what. So why does it feel better with your shoes off? That's my question.
Right.
Why does it feel better with your shoes off? They know the answer. The answer is because I'm not being held in that shoe, in a position that makes my feet hurt.
Right, but it's interesting also because he feels better in a shoe with no sock or like only one layer on his feet. So that's a neural sensitivity, right? I
Yeah.
mean, he
Yeah.
does not like, it's like wearing a piece of Spanx on your foot. He does not like that at all.
Mm-hmm.
And I think, the prostate issue, that's a good point. I hadn't thought about that because I didn't see him at that times, but he definitely had a lot of surgeries in the hernia and all of that in a short period of time. And he's very much of a thinker, but
right, high cognitive functioning.
Right.
They overthink everything. Yep.
Right.
So can he squat?
Yes.
He needs to be doing some squats.
Yeah. Yeah.
Drop down, see how he feels. Open up the pelvis a bit. Decrease the tension through the pelvic floor.
Yeah.
We'll change the tension through his feet.
Mm-hmm.
By virtue of just that neurological connection.
Mm-hmm.
That's why child's pose feels pretty good. Being able to do, but dropping down into a nice squat could be really relieving for him, both back and feet.
Yeah.
I would definitely give that a try and make it as, see if he can get it as passive as possible.
Barefoot.
He could actually,
right?
So he could actually hang there for a little bit.
Yep.
I don't know if he wants to hold on to a TheraBand over the top of the door and squat down, or the door handles and do a sit back squat. How he wants to do it, how it doesn't really matter to me, whatever feels the best. But I would definitely be adding that in as well. The other thing is with him sitting is I would still, even though he can do sit to stand better now, I would want to find out how he's doing if you vary his sitting positions. Like, where are you sitting all day long? Are you only sitting in one chair? Are you sitting sometime? Maybe you need to spend some time up, on the high top chair, or maybe you need to spend some time on the, the dining room chair instead of the couch. To vary it up and see how that happens too. Because if his pelvis is staying kind of locked in one position all the time, that may not, even though he's moving and he can stand up without pain as much, which is great. I'm just wondering if keeping those nerves so sedentary all the time isn't, that's why he's still having that. As you mentioned before, nerves are bloodsuckers and they got to move. And so he's doing the exercises, but if he's spending the rest of his day fairly sedentary, except for his walk, you may need to start breaking that up some with a lot more movement. In between, every hour, getting up and doing some different things, so that he doesn't get stiff. Because, this is my thing is like, we're an organism that should be able to adapt, and he's adapted to this sedentary lifestyle. And this is, so now he can adapt out of that. But he has to scale it back. And his way of doing it sounds like, if I can't do everything that I wanted to do, then I'm doing none of it. Because it hurts so bad. And I totally get that. But if we can kind of meet him and get him to do some of it in a different way, with the idea that your goal is to be that walker again. And we're going to work with you to get you to be that walker. That's who you are. That's what healthy looks like to you. And that's great, but we have to do it in a different way now, because your system needs to learn to adapt to a different way, because you're getting a pain response with this adaptation now, which means it's not going to be as healthy for you.
Right.
And so, if walking is what makes you it was what you see as healthy, then we got to walk a different way. We got to figure this out. We got to go shorter distances. We have to try a hiking stick. We got to get new shoes. We got to do sways. We've got to do squats. I
told him to take the bus to Central Park and then walk if he didn't, because
walking even that would work.
Versus walking in the woods. I'd rather walk in the woods. Even if it's Central Park.
Right.
At the end of the day,
if his jam is being in Central Park, then let's get to Central Park a different way.
Yeah.
And then maybe then you can start going. Okay, one subway stop before Central Park. Get out. And walk that little bit into Central Park. And then the next time it's, as you're getting better, then you go 2 stops back.
Right.
So you can kind of scale it forward and backwards many different ways. And you guys have that opportunity there in New York, to be able to.
We can. We're lucky in that regard.
Get to the park and have different modes of transportation to get there. So,
but he went back to the neurologist at one point. He was so hung up. The doctor's like, well, maybe you should get another MRI. I'm like, another one. So he literally walked in with a piece of paper and he wanted me to explain everything. And I was like, look, and I did, I was just like, Eric, don't lose your patience. Don't lose your patience, please. And I've known this guy for a long time. So, and I explained everything. And I said, I think at this point, it's generally not your back. Your back's been healed. You still have some sensitivity in the nerve. And I was explaining that to him. And I think he understood that, but then he came recently and he said, I was talking to a friend of mine, his wife, her husband's a doctor, a retired doctor. He told me to strengthen my core. And I'm like, okay, and it's like all this input. And I'm like, strengthening your core, you can do it, knock yourself out, have a great time. This is what you can do.
And you've been doing some of that. Mm-hmm.
Exactly. And I reviewed a bunch of things. So for him, he's just getting all this input and it's, I think, very confusing. And I think the last visit when I saw him, I think we determined that I'm like, this is a nerve issue. This has always been a nerve issue. It's just very sensitive now. And the fact that was bilateral, now it's more on your right, makes sense.
Mm-hmm.
And your feet feel very differently to touch because if you have a jacked up nerve affecting one part of your body, you're going to have some, increased tone in some of the muscles. You're going to have like a more of a rigid foot, not all the time, but that explains it to me. It's not like he's, both of his feet are these, very high arch, rigid feet. They're not. So my question, 1 second, I'm just looking here. The last time I saw him, he's going to do we're looking for new shoes and things like that. He wanted to, I wanted to progress his neural tension. And I had given him this, we did some squats in the office with like the TRX. So I'm not sure if I gave that for home program, but I will when I see him. But I was really focused on mobilizing the nerve in the foot, and trying to do some functional moves that would help him. Because I remember David Butler once said, everybody who has neural tension loves putting their feet in the sand. I remember him saying that at one of the classes. And I mean, he's like, who doesn't love just putting your feet in the sand and rolling around? And I said, that's probably why you feel better walking in the sand, because it kind of feels good on your feet.
Mm-hmm.
But I almost want, ironically, I said to him, I said, why? I said, why don't you, when you get to Central Park, walk on the grass?
Yeah.
Get off the pavement, walk on the grass.
Mm-hmm.
You can take your shoes off if you want. Walk on the grass. Or if you don't want to take your shoes off, I get it. Just walk on the grass and see if that makes you feel better.
Mm-hmm.
Because it's more of an unstable surface.
Right.
So in terms of progressing nerve glides, any thoughts on that? I'm doing the obvious ones on your supine, et cetera, et cetera. Forward bend or something like
right.
that. Maybe.
You can do, he can do modified cat-cow exercises like on a chair. So you can put his hands on a chair, push it up against the wall.
Mm-hmm. Hands on a seat.
Yeah, and so he's standing on his feet. He's bent over. His arms are outstretched onto a chair. Yep. And he can start exploring that spinal motion from there.
That's a good one.
Yeah, and, he can progress that down further, just depending upon how movable he is.
Yep.
But those are some fun ones and easy ones to do. And like I said, the biggest thing, too, for him is, like, getting some squatting in, and when he's sitting, really maybe even doing cat-cows and sitting so that he can actually mobilize his, just gently just keep movement going through his spine and his pelvis.
Yep.
Can be very helpful as well.
Yep. Any kind of movements.
I
like that modifies for a down dog.
Yeah.
Chair.
And that will cause him to shift forward onto his feet too some.
Yes. Yes.
So.
Yes, exactly.
Because people with this, extension type compression patterns, sometimes they've got all that quad strategy going on too.
Yeah.
To hold them up against gravity. And so if he can shift forward or sway forward, his calves are going to come on and work. But, and you can teach him that, the other thing that I would do, Erica, is the thing where you've got the 3-pronged foot and the long toes. Mm-hmm. And really have them start to lengthen those toes and stretch those toes forward and do some of that. And that's probably what was happening on the beach, is that, your whole foot gets into it. And so you're really stretching those toes out.
Yep. And
it's, just changing the dynamics rather than standing on these shoes where he's just rocking back and forth.
Yeah. That's a good point. I was just looking through my notes. I did recently, as of last week, give him some backwards walking, toe heel, heel toe,
Mm-hmm.
things like that, just to get the foot more of a focus on the foot movement in terms of just getting
Mm-hmm.
um, better gait. I'm just looking at a note from September. He went to see the neurologist, probably as a follow-up to his MRI, and she told him to curtail all his activity. And I was like, what? I highlighted it in my notes because I could not, and he was feeling pretty good at that point. He said, except the issues with the feet. But I was like, why would you tell somebody like that to curtail your activity? And so this is what we as physios have to deal with. We have to sort of mop everybody's, not poor, but just misinformation, right? It's just my soapbox. I'll get off my soapbox, but it just so irritates me
Well,
that,
they're coloring his narrative with their clinical narrative, and
perfectly
he
put.
needs and he needs to be able to create that co-narrative, and you're allowing him the space to be able to do that.
Right.
The only other thing I would suggest is if he can get one of those squishy air balls.
Yep.
And stick it under his feet and roll it under his feet and stand
Yep.
on it and move around
Yep.
on it and go up and down on it and put it under his heels and do it,
Yep.
under his toes and do it. All of those can be good. It's good for balance.
Yep. Yep.
If I don't know what he likes to do or if he wants to do, but getting the Clock Yourself app and doing the reaction stuff where it says 2 when you gotta move your foot over to 2 and 4 and all of that.
Yourself?
I don't know. I don't
heard of that one.
called Clock Yourself.
Okay.
CLOCK yourself.
Okay.
It's based on the research for posture and balance control.
I love that.
Being reactionary. And it changes the clock face to a calendar,
I love
or in different languages and different speeds and stuff. But people have to like to do that kind of stuff. I don't know what he likes to do, but that's a way to shift feet and to move around and to do a lot of different stuff, that might be more interesting than just, doing 30-second planks.
Yeah, no, I agree. I gave him a little massage ball to roll on his foot, and like I just said, if you don't have to, try a dumbbell. But I like the bigger balls. You're talking about the bigger balls, right?
Oh, they're just about, they're not, they're not
yeah,
huge.
So he has those, right?
Yeah, just get them under his feet and stand on them and
yes,
move around on them. Yep.
He's doing that in sitting, but I like it. I like the suggestion in standing. That's a good one. Yeah, so ultimately I think it's still neural. It's nothing foot related, nothing, from his back surgery. But he, the issue with the barefoot and the sand was like, I'm like, and that's why I wanted to talk about him today, because I want to get him out of that mode of he's just seen too many practitioners and he's just getting all this poor narrative. So I think that's it for me. I mean, I think this is great. Well,
this is a good one. Thanks for sharing and
thank you.
Letting us problem solve through that with you. That was great.
Yeah, I like this type of problem solving. Cool.
So
Alrighty, everybody.
You want to mention the mastermind?
Oh yes. So we are. It's never too early to talk about CSM because all the hotels get booked up and everything gets booked. So at CSM in Denver in 2020, we will, depending on when you listen to this, we will be hosting a one-day mastermind on the Wednesday before. I'm not sure what date that is. I believe it may be the 11th. It's the Wednesday. I think CSM is Thursday through Saturday, so it's the Wednesday before. We're going to have like a clinical mastermind, and we're just formalizing the details. So if you will be attending CSM and would like to come in the day before, please send us an email, erica@ericamello.com. You can send it to me, it's fine, or reach out to Susan. Susan, your email, susan@embody-pt.com.
Yes, susan@embody-pt.com.
And, or, just reach out to us on social media. But if you can, if you get on our mailing list, so if you're on the mailing list already, you'll hear about it. Our website is toughtotreat.com. And if you opt in and sign up, you'll get a couple PDFs from us initially, but you'll get updates on the mastermind as well. Okie dokie. That's it. Thanks, everybody.
Okay. Bye.
Bye.